Okay, so it's 8:01. I think we can get started. Welcome everyone. Today's webinar is on exclusive breastfeeding promotion in Southeastern Nigeria. If this is your first time joining us, we're Maternal and Infant Health Canada. We're a global public health organization devoted towards improving the lives of women, children, youth, and the environment through education, research, and innovation. To learn more about our work and to join in as a speaker, researcher, or contributor, please email us at mecancares@gmail.com. I'll put that email address in the chat. You can also follow us on Facebook, and I'll put that in the chat as well. Finally, if you want to see any previous webinars or revisit this one afterwards, you can go on our website at maa.med.ubc.ca, and then go on the education tab, and you can find all of our webinars there. So as I said, I'll put all of those contacts in the chat, and please feel free to connect with us later. My name is Ava Sullivan, and I'm going to be filling in for Dr. Emily Solomons, who normally moderates these webinars. I'm zooming in today from the traditional unceded lands of the Musqueam, Squamish, and Tsleil-Waututh nations here in British Columbia, Canada. Please feel free, as I said, to write your name and where you're joining in from in the chat. We'd love to see where everyone is calling in from this morning, or maybe it's night where you're calling in from. And today we're so fortunate to have Dr. Obinna Ekwunife and Izuchukwu Ejie, I hope I did that okay, as our presenters. Dr. Obinna is a Takimi Fellow in International Health at Harvard School of Public Health and an Associate Professor in the Department of Clinical Pharmacy and Pharmacy Management at Nnamdi Azikiwe University in Nigeria. He is also the Program Manager of the Social Innovation and Health Initiative Nigeria Hub, which is a World Health Organization sponsored project that aims to identify and promote social innovations in health in Nigeria. We're also joined by Izuchukwu. She is a lecturer and PhD student in the Department of Clinical Pharmacy and Pharmacy Management at Nnamdi Azikiwe University. Before we get started, just a quick disclosure, as with all of our public health webinars, this course and handouts may contain general information about medical conditions and treatments. And this information is not advice and should not be treated as such, but it is an educational opportunity for you all here today. I'd like to invite you to, as questions emerge, to write your questions in the chat, and I'll do my best to capture them during the presentation, and then we'll have some time for a Q&A at the end. So please write all your questions or comments in the chat, and we'll have a further discussion at the end of our session today, which will go until, it will be a 1-hour session. So without further ado, I will pass it over to Obinna, and thank you very much.
Thank you very much, Eva. So good morning, good afternoon, good evening, everyone. So today we're going to present the work which we have been doing for a couple of years now. We are trying to promote exclusive breastfeeding in Southeastern Nigeria. So the learning objective, we want to understand the facilitators and barriers to exclusive breastfeeding in Sub-Saharan Africa. We are going to understand the barriers of exclusive breastfeeding in Southeastern Nigeria. Then we'll learn the development of an educational intervention, which we developed to address the issues with exclusive breastfeeding. So as a way of starting, there is increased concern globally and regionally about the declining exclusive breastfeeding practice. And we know that the World Health Organization recommends that babies should be exclusively breastfed for this first 6 months of life. And in 2012, the World Health Assembly approved, the global nutrition target of increasing the rate of exclusive breastfeeding to 50% by 2025. Well, the data we have, it's showing that we are not meeting this target. Now, in Nigeria in particular, Nigeria has the lowest exclusive breastfeeding rates in Africa. In fact, the Nigerian Demographic and Health Survey in 2013 shows that the rate of exclusive breastfeeding is just 17%. And it's quite, well, appalling, because exclusive breastfeeding is, is free, and with that, you can do a lot. So if you exclusively breastfeed, we can save 13% of annual deaths, and yet we are not using this intervention. Just a bit about the country we want to focus on. Nigeria is in West Africa. It has a population of 261 million, has a GDP per capita of about 2,000, and has a very high fertility rates, about 5.2 births per woman, and a very young population rather. So today, to solve this problem of exclusive breastfeeding in Southeastern Nigeria, we first of all wanted to understand the barriers and facilitators of exclusive breastfeeding in Sub-Saharan Africa. Then we focused on Nigeria to understand what the problems are, and we developed an educational intervention to solve the problem. So I'm going to hand over to Izuchukwu Ejie, who is a PhD student that really did this work, to expand more on this work. Thank you, Izuchukwu Ejie, over to you.
Thank you. Thank you, Professor Ekunife. I'm Izuchukwu Ejie. I'll quickly start from where Professor Ekunife stopped. So the phase 1 is a qualitative systematic review. We actually carried out a systematic review to review literature that reported barriers and facilitators of exclusive breastfeeding from the breastfeeding mother's perspective in Sub-Saharan Africa. And to do that, please, next slide. Next slide. So we searched Medline and Google Scholar, and we retrieved about 677 studies. At the end, only 20 studies were included for this systematic review. These studies were assessed for bias and methodological, and they had moderate risk. So 2 authors carried out this review process, and any disagreements were resolved through consensus. The data generated from the 20 included studies were analyzed thematically. Please, next slide. So the result after thematic analysis showed that there are 3 basic barriers that discouraged mothers from practicing exclusive breastfeeding. And these barriers are barriers associated from the mother and the infant, and barriers associated from the support structures such as the husbands, the healthcare, and the workplace, and the barriers associated from the tradition, the sociocultural beliefs, the norms. Next, please. The maternal and infant factors, barriers. A study revealed that it is the major barrier. It is the major demotivator. It actually made mothers not to practice exclusive breastfeeding. From the mother's point of view, they've reported that their work, both formal for those who are in the formal environment and their informal workload and work schedules, discourage them from practicing exclusive breastfeeding. Those who attempted to practice gave up along the way because they perceived their breast milk was insufficient. Others had issues of the effect on their appearance, where they felt if they went on to breastfeed their children exclusively, it could affect their appearance. Some others reported they couldn't practice exclusive breastfeeding because they did not understand it, because there was not much awareness. People who were supposed to tell them about it, the healthcare workers, didn't do much, so they didn't know anything about it. Then those who were HIV positive were scared of transmitting this virus to their children if they were to be breastfed. Then the young mothers who are still in school also reported that schooling or resuming work, those who were working, were part of the reasons why they couldn't practice exclusive breastfeeding. Those who were working revealed that the maternity leave given was too short to practice exclusive breastfeeding. Some others reported that poor nutrition on the part of the mother was part of the reasons why they couldn't exclusively breastfeed their children. Others could not breastfeed their children because of the discomfort and embarrassment they face in public when they want to breastfeed their children. Some others did not get the approval they needed. Some of the infant factors studies revealed were crying babies, which the mothers felt indicated that the children were hungry. Mothers felt that their children crying showed that they were hungry even after breastfeeding, and such that the breast milk was not enough. Difficulty in children latching or positioning, especially the first-time mothers, they reported they couldn't get their children to latch properly, and it was a problem. This is because they didn't get the support, the practical support from the hospitals. Then other infant issue like sick babies, where the child had to be hospitalized in intensive care units, and the mother, out of frustration, gave up on practicing exclusive breastfeeding. Then there are some breast-related issues that these mothers also reported made them not to practice exclusive breastfeeding. Some of them are cracked or painful nipples, and some mothers perceived that their breast milk was too light and has lousy odor, such they refused to practice exclusive breastfeeding. Some of the quotes we had from these mothers are, if I have much work and she wakes up, I can't give her much formula so that she can sleep. I introduce other food mainly to free myself for more work. This is a case of a woman who feels her work is more important and she has to give her child other feed so that she can concentrate and work. Then another quote is, I start to give my child cow milk at the age of 3 months because I believe that only my breast milk was not enough. This is a case of perceived breast milk insufficiency. Then in our community, young girls like me do not like to breastfeed. They are afraid that their breasts will sag. This is a case of young mothers who feel that breastfeeding could affect their appearance. Then the last quote is, when I breastfed, the baby will still be crying. So this is the infant factor, where the mother perceives that the baby is crying because he or she hasn't gotten enough. Another barrier to the practice of exclusive breastfeeding is support structure-related factors, where family influence of health system, and workplace posed as barriers to the practice of exclusive breastfeeding. Mothers reported they didn't get the necessary support from their husbands, from their mothers, from their family members, and painfully, they didn't get the necessary or the expected support from healthcare workers, where the healthcare workers even discouraged them from practicing exclusive breastfeeding. Others blamed inadequate breastfeeding education, counseling, and support from healthcare workers as their main reason why they did not breastfeed their children exclusively. Some mothers revealed that they didn't get the support from their workplace, where their head in their workplaces gave them a situation of choosing between breastfeeding their children and their work. And others blamed the short maternity leave as their reason for not practicing exclusive breastfeeding. The quotes that they shared are, "Nobody ever showed me how to breastfeed my baby. It was not as easy as I thought. With time, I learned. I think if a nurse could come and spend just a few minutes with me talking about breastfeeding, it could help me to open up." This is a case of a mother who would have practiced exclusive breastfeeding but couldn't because she didn't get the required support from the healthcare. The mere mention of the denial of water made my husband to condemn the practice. So this mother who made this statement complained that the husband did not support exclusive breastfeeding because he insisted that water must be given to the child. I had little challenges with some healthcare workers. It was only the doctor that was advising me positively. Some of the workers were like, "Don't mind the doctor. If you must breastfeed your baby, it should be like 3 months." This is a case where a mother got the wrong information and could not practice exclusive breastfeeding. The last quote is, "I can't do this exclusive breastfeeding thing because in school, my headmaster keeps shouting at me that it is taking away work time. He even asked me to leave the baby at home. I don't want to lose my job." This is the case of a woman who had to choose between her work and her child because she didn't get the necessary support from her workplace. Other barriers that some of these studies reported are influence of the norms and beliefs and the traditions, the social and the cultural trend in the society when they gave birth. So some reported that they were forced to use some herbal concoctions as medicines. One person quoted, "The main barrier that I may highlight is cultural norms and values. You find that in this African setting, when a woman gets married and lives with her in-laws, when she gives birth, it is said that the baby belongs to the family of the husband, to the extent that she's supposed to live according to the standard and norms of that particular family. If the mother-in-law believes that the babies are supposed to be given solid foods, even at birth, even the prelactal feeds may be the grail or something she'll be forced to do, even when she doesn't want to." This is when a mother reported that she had to succumb to the pressure from the culture and because she wanted to preserve her family. Then, coming to the facilitators, the factors that motivated these women to practice exclusive breastfeeding. After thematic analysis, we found things and factors related to the mothers, related from and sociocultural beliefs, factors related to the family finances, and finally, environmental factors. Next slide, please. Mothers revealed that they were motivated to practice exclusive breastfeeding because they have a positive opinion about exclusive breastfeeding and they knew the benefits. And having known the benefits, they made up their mind to practice exclusive breastfeeding. They reported that they were committed, that exclusive breastfeeding is about commitment. And they set out their minds to practice it. Then some other mothers reported adequate maternal nutrition as a strong motivator, as a child is said to be what the mother eats. So because she was feeding well, she was motivated to practice exclusive. Enjoy breastfeeding my baby. Then some infant factors that encouraged mothers to practice exclusive breastfeeding are the understanding that exclusive breastfeeding gives better cognitive development and that it also protects children from getting infection. Next slide, please. A major factor that motivated mothers to practice exclusive breastfeeding are the influence of family members, the husband, and other family members. In a quote, a mother said, "My mother-in-law encouraged me to breastfeed my children, but also my mother, especially with my child that was delivered at home. She encouraged me to breastfeed because there was a time when I wanted to go back to work, but she insisted that I first wait for the child to grow. I was patient." This is a case of a mother who had support from the family members, and this made her breastfeed her children exclusively. Another facilitator is for some women are workplace support. Some mothers reported they had some workplace support and they had longer maternity leave. Others reported that they had a nursery at the workplace where they could come to work with their children, giving them time to...
I can take over since I worked with her on the project, if you don't mind. Okay, so so she was talking about the facilitators of exclusive breastfeeding, and apart from the workplace support, had also health system support, which is the influence of healthcare workers where healthcare workers encourage exclusive breastfeeding. For example, in this quote, it says, "When we were at the clinic, we started by learning about feeding the baby for 6 months, not giving him water, but making him drink breast milk only." Okay, another facilitator is influence of traditional and socio-cultural beliefs. So socio-cultural beliefs, we have breast milk is the only food for infants and a natural gift from God. You know, where in societies where they have the right knowledge about exclusive breastfeeding. Also, breastfeeding is a traditional practice. Breastfeeding that believe that colostrum is good for the baby and fear of discrimination. For example, we see in this quote, breastfeeding is a traditional practice. There is even an Igbo axiom that says that any child who does not suck breast milk well will not have common sense and will not be intelligent. So this is, you know, a society that has the correct information and beliefs about exclusive breastfeeding. We also have influence of family finances. So, so when people are well-to-do, it really helps exclusive breastfeeding. And also environmental factors like or good hygiene practices. Okay, so the main finding from this systematic review was that maternal infant factor played the most significant role in acting as a barrier towards breastfeeding, and also helping people to practice breastfeeding. So maternal employment and knowledge of the belief of exclusive breastfeeding were the most common maternal infant factors that serve as a barrier and a facilitator respectively. So we entered the phase 2 of this study. So remember, the first one is a systematic review of what happens, already published study in sub-Saharan Africa about what facilitates and cause and barriers towards exclusive breastfeeding. Now I wanted to zero down in Southeastern Nigeria to understand context-specific barriers towards exclusive breastfeeding, since our target is in this region. So again, we did a qualitative study with phenomenological study design. It was conducted in Southeastern Nigeria. We chose rural and urban health facilities. So we interviewed women that were coming to the clinic for antenatal or postnatal in health facilities or hospitals in rural and urban facilities. So we focused basically on mothers who did not practice exclusive breastfeeding. So they were asked whether they practice exclusive breastfeeding. So people that said no were not interviewed. What we got, we thematically analyzed. So basically, these are the results we got. So we had a total of 4 teams and 7 sub-teams that we identified as recurring barriers to exclusive breastfeeding in Southeastern Nigeria. And these teams basically were maternal infant factors, support structures and related factors, economic factors, and traditional and social cultural beliefs. Again, the major team that came out clearly was maternal infant factors. Right, so in these maternal infant factors, in the maternal side, we have mothers' formal work, employment, and informal work schedules that made them not to breastfeed. We also had perceived breastfeeding and perceived breast milk insufficiency, delayed milk letdown as a barrier. Some poorly understood what exclusive breastfeeding was and the benefits of exclusive breastfeeding. Mothers going to school or for school run or resuming school or work really acted as barriers. Type of delivery also affected exclusive breastfeeding. Sick mother and people that didn't have, didn't get pregnant, didn't get pregnant, also affected breastfeeding. So this quote is an example. And here the lady said exclusive breastfeeding is not good because water is very necessary and not breast milk all the time. Another said, this is my first child. I do not practice exclusive breastfeeding because I did not understand it. Another said, I have big breasts and they do not produce enough milk. So the other barrier is impact factors, like people that have multiple births, unsatisfied baby, that after feeding, they keep crying, infant difficulty, latching, opposition, and refusal to breastfeed, to prepare a child for weaning, stature and size of baby, sick baby, and baby teething. So one thing is we also saw some ideas that we found during this systematic review also repeating in Southeastern Nigeria. So for example, to give an example, a lady said, I can't give the twins only breast milk. It won't be enough for them. Another said, my baby is always sucking. He does not sleep at night, but sucks throughout the night. But the day I decided to give him water, he slept very well and did not cry as before. Another said, my baby is too lean, so I had to add Complan milk so that she will be big. So another factor is breast-related factors. Some breast conditions, cracked, painful, or sore nipple. For example, a lady said, my nipples pain me badly anytime I give him breast milk. I had to introduce formula milk. Okay, the second theme, which is the second barrier we saw is support structure related factors. So family and friends influence. For example, influence of husband, mother, mother-in-law, and other family members and friends. An example is a lady saying, I was giving my baby only breast milk until my mother visited and insisted on giving him water. Then also influence of health system. So influence of healthcare workers, such as inaccurate, conflicting advice or message shared by healthcare workers, and inadequate breastfeed education, counseling, and support by healthcare workers. An example, a midwife advised a lady to give her baby water and glucose immediately after delivery. My doctor told me that exclusive breastfeeding for mothers who cannot hygienically take care of their baby. So these are very strong misconceptions, even by healthcare, perpetuated by healthcare workers. Another is economic factor, lack of resources to ensure adequate maternal nutrition. For example, a lady said, I'm feeding 3 square meals was a problem for me, so I cannot practice exclusive breastfeeding. There are traditional and social cultural beliefs. For example, to avoid contaminated milk, practice of giving water, it's very, very common. And For example, a mother said, my mother gave me water, so I must give my child water. Also, I stopped exclusive breastfeeding at 3 months so that my baby will not suck my blood deposited by my husband during sex. So these are some of the real wrong misconceptions people have. Okay, that we saw. So summary. So findings from both the systematic review and the qualitative study in Southeastern Nigeria reveal that maternal infant factors were the major barriers to exclusive breastfeeding. So it's interventions that focus on addressing these maternal infant factors are therefore of great importance. And addressing these challenges will promote exclusive breastfeeding practice with its intended benefits, and which will ultimately improve child's outcome, maternal and child outcome. So taking from what we already know in the literature, we know that promotion of steps to improve exclusive breastfeeding, basically promotion of EBF is vital public health strategy. And there are different steps globally to improve it. One is a belly-friendly hospital initiative launched by WHO and UNICEF in 1991 to implement practices that protect, promote, and support breastfeeding. So we also have World Breastfeeding Week, which started in 1992 to generate public awareness and support breastfeeding. We also have efforts from the World Alliance for Breastfeeding Action, which is a global network of individuals and organizations dedicated to the protection, promotion, and supporting of breastfeeding and breastfeeding worldwide. So we looked at all this literature and looked at the problems. And with that, we tried to design a hospital-based counseling guide, which could help to address some of these barriers we have identified. So this was the third phase of this work, and is currently ongoing. So this is, as a background, even though breastfeeding is a natural act, it's also a learned behavior. So, and I think Izuchukwu is online now, and I will allow her to continue where she stopped. Thank you, Izuchukwu, over to you.
So even though breastfeeding is a natural act, it is also a learned behavior, because mothers can learn the act of breastfeeding through information gotten from support from their families and communities. They need to have access to this practical help, which will build their confidence and improve their feeding techniques. Also, it will prevent and resolve any breastfeeding problems these mothers may encounter. So our intervention aims to improve nursing mothers' understanding, acceptance, and then practice of exclusive breastfeeding. So in formulating this intervention, we, like earlier stated, the intervention was designed to provide the required knowledge that these mothers need. And this will be employed during the antenatal and postnatal clinics. In preparing this guide, information was obtained from the World Health Organization Infant and Young Child Feeding Practices Manual, and also from the Federal Ministry of Health Antenatal Care Retention Package for healthcare providers. Next slide, please. Most importantly, information from the formative study. Next slide, please. Information from the formative study, where we had to critically look at those barriers that these mothers reported as their reasons for not practicing exclusive breastfeeding. We brought out solutions to these barriers and integrated in the manual. The hospital guide was given to 4 healthcare workers for their expert opinion. This is to ensure that we come up with a rich counseling guide that is robust and has all the necessary information included. So with the input of the 4 healthcare workers, the final version of the hospital-based counseling guide was produced and then validated by an education expert. Next slide, please. So we started the home trial. The home trial is ongoing. The aim of the trial is to evaluate the effect of this counseling guide in improving exclusive breastfeeding practice in 12 hospitals which were selected in Anambra State. This trial was registered prospectively in the Pan-African Clinical Trial Registry on 14th March. Next slide, please. Our primary objective was to evaluate the effect of a hospital-based maternal counseling guide on exclusive breastfeeding practices. And the secondary objectives are to assess the knowledge, attitude, and practice of exclusive breastfeeding practice of the study participants before and after the intervention, where we are having a pre-intervention questionnaire and a post-intervention questionnaire to assess CAP. Then secondly, to evaluate the changes in child health, height, in child weight for height Z-score and height for age Z-score. This scores measures the stunting and the wasting of the child. Then the third objective is to assess the mothers and the study personnel's experiences, facilitating and limiting factors associated with our intervention. Next slide, please. Home trial is a cluster randomized controlled trial which is conducted in 12 selected hospitals. 12 hospitals were selected based on the inclusion criteria, and these hospitals were randomized into intervention and control arm. Recruitment of the participants was done in the second pregnancy trimester. Next slide, please. And mothers were included if they were of the ages between 18 and 50 years and in their second trimester, and also living within the catchment area and intending to stay for the next 1 year, because this is because the study is going to last for at least 9 months. So we included only mothers who will stay for that long, and also pregnant women who were willing to give their informed consent to participate in the study. Mothers who were sick or mentally unstable were excluded from this trial. The intervention hospital received the formulated hospital-based counseling guide, and the trial nurses in those hospitals were also trained on exclusive breastfeeding and how to use the formulated counseling guide. The intervention was in the third pregnancy trimester and will continue till after birth. This is the time we are going to evaluate. And the comparison of usual care did not receive any training or education on exclusive breastfeeding. The hospital usual care is a care that is specific to that hospital, which usually do not have some questions that during clinics or anything that the nurses deem fit. This is part of the reason why we wanted to have a manual which will be standard and will not be a subjective exercise every antenatal clinic, where mothers will always have a guide that they will be taught from in every antenatal and postnatal clinic. Initiation of breastfeeding within 1 hour. Use of only colonies in childhood for next.
Yeah, thank you very much. So I think she has almost ended. So she was just talking about the primary and secondary outcomes of the cluster randomized trial, and just to end that this the findings of this trial will provide evidence on the feasibility of applying a standard maternal counseling guide, which is intervention to improve exclusive breastfeeding during antenatal and postnatal attendance in clinics. And it's feasible and effective. We improve the practice of exclusive breastfeeding in Southeastern Nigeria. So I think these are the major references. And thank you, everyone. We are so sorry for the internet connection from Nigeria, which sometimes can be a bit challenging. Thank you, everyone.
Thank you so much. So I have a couple of questions that have been coming in through the chat box. You mentioned, you talked about the structural barriers that prevent women from breastfeeding. I'm wondering, what are the strengths of health policy in Nigeria that support breastfeeding and other aspects of women's health?
Yeah, so in terms of policy, we have very good policies. But I think the problem is implementation, so the policies don't translate to practice. So, and what we have seen that is a bit worrisome is that some of the healthcare professionals that may, especially the lower cadre professionals, not the doctors, but the nurses, the assistant nurses, and they even have the wrong idea about exclusive breastfeeding, and they're passing on this wrong information. So I think that's what the intervention wants to solve. So the intervention, first of all, is to have like a manual, a guide that can be used in these hospitals, and that is a bit structured, and that can help to pass the message correctly. And of course, address some of the wrong ideas already about exclusive breastfeeding. Thank you.
Thank you so much. Ramya asks, the intervention/guide is focused on exclusive breastfeeding, post-birth effects. Is there a reason for documenting birth weight as an outcome measure?
So I think, yes, so I think the idea, that's why it's a secondary outcome, but the idea is to see whether it also affects stunting in the long run. We're just curious about that, to know whether it will affect stunting in the long run.
I have a question as well. I'm wondering if you could speak a little bit about the perinatal model of care in Nigeria. So do most women see a midwife prenatally, or do they go to a clinic? And do you see differences in exclusive breastfeeding across different types of care?
Let me, Izu is back. Let me allow her to answer, since she's like the major person in this world.
Okay. Hello, can you hear me?
Yes, we can.
Okay, what's the question, please?
Sure. I was just asking if you could provide a bit of context around what the model of care is for women in Nigeria. Maybe there's several different types of models, so whether they see a midwife, whether they see a physician, go to a clinic, etc. And do you see differences in breastfeeding rates, I guess, across different types of providers or different types of care?
Yeah, thank you for that question. We observed that was the essence of doing the qualitative study. And in our qualitative study, we did have some that were carried out in the rural area and some that were carried out in the urban area. Majority of these mothers visit the hospital. So depending on.
So I think she's trying to say that, of course, so women go to the formal sector, that's the hospitals, while some don't go to the informal sector. But our now I don't know, I can't give you the stats now. I know that in Southeast it's a bit better in the sense that a lot more women go to the hospitals than like betting homes. But our focus here is in the hospitals, you know, so the information they get from the hospital when they come for antenatal and postnatal care. So wanted to make sure that they're getting right information. So our intervention is actually targeted at women going to the hospital to give birth.
For sure, that makes sense. Thanks. And then we just have one final question for you to wrap up the session. Someone asked, is there any evidence-based discrepancy between children who were exclusively breastfed and those who were not exclusively breastfed? I'm not sure if this is just physiological outcomes that this person is asking about, but maybe you could speak to that a bit.
Yes, so while I presented, there's strong evidence showing that exclusive breastfeeding is very beneficial. And as a matter of fact, if you practice exclusive breastfeeding for the first 6 months, you could avoid 11% childhood mortality. So it's a lot of impact. If you think about that, there is strong evidence showing that exclusive breastfeeding is very, very effective and very important. It saves life even. Yeah.
Thank you so much. That was an excellent answer. And that's all of our questions for today. Thank you again so much, Obinna and Izuchukwu. Farah, I'll pass it over to you for any final words. Oh, you're on mute, Farah. No.
Okay, there we go. Hi. Thank you so much, Ava, and thank you so much, Dr. Obinna and Professor Ejie for a wonderful, wonderful webinar. If we do have a few minutes, may I ask another question? Is that possible? Could I ask both of you, what is the role of fathers and men in promoting breastfeeding, really specifically to the cultures you're talking about in Southeastern Nigeria? Can you talk about how decisions are made to breastfeed? In a lot of the work I've done, many of those decisions are actually taken by fathers and men. So I'm wondering how men can promote breastfeeding as well.
Yeah, I mean, so we saw from informative studies that sometimes issue comes from men as well. For example, as even people, men that don't want their wives' breast to sag, for example, or not supportive, and it really affects the issue of exclusive breastfeeding. So of course, if men are well informed and they help their wives, of course, certainly we will see better rates of exclusive breastfeeding. So of course, men are very, very important in the whole process as well. Unfortunately, I don't think the educational intervention is addressing that as well. It's more on the women attending when they attend antenatal care to get the correct information on exclusive breastfeeding. Farah, you're muted.
Great, thank you. The host wasn't allowing me to unmute. Sorry, there was a nice comment in the chat there by Maureen that said that men are encouraged to attend antenatal clinics with their wives to get adequate information. Like I personally think this is a really, really important part of breastfeeding and the entire reproductive cycle of encouraging and involving men makes a huge, huge, huge difference.
Yeah.
And on that note, I just want to welcome our guests who are here. We've got Dr. El Hadi, who is a Sudanese obstetrician here. We've got Dr. Lagobe, Dr. Henry, who's an East African physician. We've got one of our new MyCAN members, a medical student, Madison, who is running our campaign for Reduce the Stigma. We've got Simran, who's a medical student as well, who's a new member. And I just want to acknowledge all the other people who are here today. Vanessa Chang, Ugochi Adenola, Rachel Olusa, okay. Sorry, my thing moved. I can't see the last name. Okay. Agu Jobi, Mercy Nwadu, Maureen Antejo, Lizette Ezinekwe, Litel Sharvet, Ifemoa Ume, all of you who've joined us. Halima Khatum, thank you. Yeah, thank you for joining.
So the children need that acquired immunity from their mom, that first 6 months. So one thing I know from my family is that the first child that was exclusive breastfed had less incidence of malaria, for example, compared to the last one that was not exclusive breastfed. And we're talking about developing countries where we don't have a lot of health technology to treat infections. So why don't you protect the child with exclusive breastfeeding? So again, there is evidence showing that if you practice exclusive breastfeeding, you can lower childhood mortality by 11%. So that's a lot. That's a lot of life lost. So why don't we use this natural intervention, for example, which is natural. We don't need to spend money on that. So exclusive breastfeeding is very good if you can really get it on and practice again. Unfortunately, we are losing the culture and a lot of information going on around. In the terms, I can check the literature, but I can check literature to answer your question in terms of if it has other effects, developmental effects. But I'm sure it will. I'm sure it will. But I can answer that I can get back to you with that. Thank you.
All right, I will appreciate it. Thank
you. Thank you so much, okay, for asking that question, and for all of you for participating. I'd just like to add that there are some practices, some cultural practices, like feeding babies a little bit of water or something right at the beginning when they're born, that are actually harmful to exclusive breastfeeding. And so that's why those of us who work in this field really try to encourage the entire family to do exclusive breastfeeding, at least for the first 6 months, like no water, no form. And for those women who can do it, it's best for women's health and best for the infant's health. And with that, I would just like to say thank you to Dr. Obina and to Professor Ijechukwu and to Healthy Seminars for hosting the maternal and infant health webinar. And just thank you all for participating today in this very, very, very important webinar. And be well and bye-bye. And you're welcome to unmute and say something. And Maureen, thank you so much for all your wonderful comments in the chat. Thank you.